I'm very glad to see you all here. This is my last talk, and I've been talking like crazy if you guys have heard me. So if I run out of breath, I have a helper on this talk. I am later going to introduce my research assistant, Natalie Ayari, who has been working with me for about a year now and has been working a lot on our project at looking at ADHD in kids with all the different variations. So this is what we're going to talk about, is attentional problems and ADHD. So first we're going to talk about, for attention problems, when is it a disorder and how is the diagnosis of ADHD actually made? What are the subtypes of ADHD? A lot of parents are like, he doesn't have ADHD because he doesn't have the H. He doesn't have hyperactivity. And there's actually, a subtype of ADHD that's the predominantly inattentive subtype, and they don't have to have the H, or they don't have to have hyperactivity and impulsivity. And so we're going to talk about the different subtypes. We're going to talk about other causes of attention problems, because clearly not all attention problems are purely, a brain-based neurological deficit in attention. If kids are having attention difficulties in school, there can be a lot of other causes. And so I think in our kids who can have a lot of, different features and different areas of weakness, then we want to make sure we're paying attention to all those different pieces. Natalie's going to present the research that we've done on ADHD and the different X and Y variations, the rates that we've seen in our practice, and then other factors that seem to influence the ADHD symptoms. And then I'll talk again about treatments of ADHD, including behavioral interventions and medication treatments. So, like I said before, not all attentional problems are ADHD, and there's another slide coming up that lists all the different things that you need to consider when you're talking about whether or not a diagnosis is ADHD. The main features of attention deficit hyperactivity disorder are inattention, hyperactivity, and impulsivity. And so in the general population, we know the diagnosis is made in about 3 to 8% of children, and it's much more common in males and females in a 3-to-1 ratio. In our X and Y population, our rates that we're finding are significantly higher than this, and so and that's why we think it's an important topic to discuss with you. There's subtypes of ADHD. There's the predominantly inattentive subtype, and this is what's typically, or classically known as ADD. So these are kids who don't have a lot of problems with hyperactivity and impulsivity. They may be a little fidgety, or but they're not the ones bouncing off the walls. A lot of females are more likely to have the inattentive subtype, or ADD, than males are, and not. So if a female has ADHD, they're more likely to have the inattentive type than they are to have the hyperactive or combined type. Females tend to be, quietly inattentive, and that's important to recognize, and it's also important to recognize in the boys who have it, because they're not causing a lot of problems in class usually when they don't have those hyperactive or impulsive behaviors, but they can definitely be inattentive and still, having that affect their work and their school performance. And so, teachers are less likely to pay attention to that and call your attention to that because the kids aren't causing them problems, so they may be missing them in the classroom. And then there's a predominantly hyperactive impulsive type. This is actually very, very rare, just to have hyperactivity and impulsivity, but have a good attention span. And so this is rarely diagnosed. I don't think we had anyone who actually met this criteria. And then there's the combined subtype. And combined means they have, the attention deficit and the hyperactivity and impulsivity. So symptoms of inattention. So these are, and if you guys want to know, does my son or daughter meet criteria for ADHD? These are actually the diagnostic criteria. So if you want, as we go through these lists, count how many check marks you're making on whether or not your child has kind of moderate to severe difficulties in these areas. But difficulty sustaining attention in tasks or play activities, difficulty organizing tasks or activities, being distracted by extraneous stimuli, losing things necessary for activities such as toys or school assignments or pencils, avoiding or being reluctant to engage in activities that require sustained mental effort. So I get a lot of questions about, oh, well, my son can't have ADHD because he can sit there on the computer and play video games for 3 hours. Well, video games are very engaging and they're changing and, they require you to be engaged with it, but they're also, they're not challenging your attention. They are giving you everything that you need. So it's not a challenge to your attention. He can watch TV for hours at a time. Well, TV again is changing and it's giving you a lot of information. Can he watch a boring documentary for 3 hours at a time? Or something that would be more, something like a school program that he has to watch for 3 hours at a time. And so those are the types of things that, the statements of, well, he can play video games for a long time or he can watch TV for a long time, that's not, those are very engaging and they're giving you a lot of feedback. And kids with ADHD, need that feedback. And so you can still have ADHD and be able to play video games. Inattention does not follow through on instructions. So this is, often, okay, go upstairs, get your backpack, get your shoes, brush your teeth, and come back down. And, they get up the stairs, and then you never see them again. Like, that's it. And so, can they follow through on multi-step tasks, keep that in their mind, and actually finish the instruction? Do they give close attention, fail to give close attention to details, or make careless mistakes in schoolwork because they're kind of skipping by things or not really focusing on what they're supposed to be doing, being forgetful in daily activities, or not seeming to listen when spoken to directly? They're off thinking about this, looking at that, thinking about something else. And then the symptoms of hyperactivity and impulsivity: fidgeting with hands and feet, squirming in their seat, being on the go or feeling like they're driven by a motor, always moving, always going, blurting out answers in class, having difficulty awaiting their turn, not being able to stand in line or always having to move, interrupting or intruding on others, butting into conversations and games, leaving their seat in the classroom or other situations in which remaining seated is expected, having difficulty engaging in leisure activities quietly, talking excessively, or running around, climbing excessively in places where it's inappropriate. So those are all the criteria. And then to actually make the diagnosis, basically, to meet a diagnosis of ADHD, you need to have either check marks that are, moderate to severe impairment or moderate to severe difficulty in 6 or more of those first inattentive symptoms, or 6 or more of the hyperactive and impulsive symptoms, and also know that the symptoms are present before 7 years of age. If someone is 13 years of age and has had no attentional problems and no behavioral difficulties and all of a sudden has a hard time paying attention, ADHD doesn't present at 13 or 14. So those make you more concerned about, is there something else going on in his brain? Someone who's deteriorating and has never had that chronicity of problems from when they were young, we are concerned about other things. So we want to know, at least some of these symptoms. They don't have to have met full criteria, but were there some indicators before 7 that something was present? Are the symptoms present in 2 or more settings? They don't have ADHD if the only place they can't sit still is at church, right, or at school. If they're only not paying attention at school, and it's only in math class, well, that may be a sign to you that maybe it's something with the way that math class is set up, something with the teacher, something about learning math. So you want to make sure that you're seeing these symptoms, in at least 2 places, at school and at home. They can be more significant in one place or the other because the demands of the school setting are more significant. But they're definitely, you want to see that you're seeing some, the perfect little angel at home and then horrible problems at school. You need to really look more into kind of what's going on at school and what's the discrepancy. Symptoms leading to clinically significant impairment in social, academic, or occupational functioning. All of these behaviors describe kind of typical kids in some ways, right? You're going to be a little hyperactive, a little impulsive, boys will be boys, all those types of things. So when is it impacting them? Well, when it's actually causing impairment in these problems. So, when you're affected by them, then it is more a disorder as opposed to just a normal variation of behavior. And then they need to be present for at least 6 months to make the diagnosis. So what we use for children in the diagnosis are parent and teacher rating scales, and many of you have probably filled these out if people have concerns about your child's attention. And there's a lot of different names for them: the Connor scales, the Vanderbilt scales, the NICHQ checklist, the SNAP rating scales. And they all basically contain all those criteria that I provided at the beginning, and you're supposed to rate whether it's sometimes, very often, very, very often, very, very, very often, and you never know exactly what to put because they're kind of in the middle, or maybe they're here, or maybe they're there. Or sometimes it's very clear where to put, it's all the time, or it's none of the time, you know? And so you guys have probably, or some of you may have filled these out. The diagnosis of ADHD can be made by a pediatrician or a family practice doctor by using these checklists. And as pediatricians, we're trained to use the checklist, to ask questions, and then to do medication management for simple ADHD. This, you know, a good pediatrician can do this and can sometimes do it very well. The only thing is that pediatricians don't always understand the complexities of the X and Y variations in terms of their other factors that can be involved. And so you also, I think it's very important that when we're making a diagnosis of ADHD in the kids with the X and Y variations, that you have another kind of psychological assessment by someone who understands the variations to be able to look at things like learning disabilities, executive function, speech and language functioning, all those other things that can impact behavior and attention in the classroom. Psychologists can make the diagnosis of ADHD. Psychiatrists, neurologists, developmental pediatricians are often also specialists who make the diagnosis. The schools shouldn't actually make a diagnosis of ADHD. Schools shouldn't be making diagnoses, medical diagnoses that require medical treatments. But it's okay for them to call attention to behavioral and attention concentration difficulties at school. And a lot of parents first hear concerns about ADHD from teachers at school. And teachers at school, well, you know, sometimes they can be villains, you know, and horrible for the kids with the X and Y variations. Oftentimes, you know, they're really great advocates for the kids, and they have a really nice picture of what typical kids in that age group and that setting and what's expected of them. And so if a teacher is calling attention to behavioral difficulties in the classroom, you know, they usually, now not all teachers, but they usually have a pretty good perspective of, you know, how the other kids are able to self-regulate, pay attention in the different settings. And they don't tell every parent of, most teachers shouldn't tell every parent of every child who might be having problems. You know, they're going to tell the ones at the extreme ends. And so if you're hearing it brought up at school, it's usually, you know, something to pay attention to and to have further evaluated. The things, again, like I said about the teachers, though, is that they notice those kids who are disruptive. And so if you have concerns about, you know, progress in academics and attention span at home in those kids who are more quiet ADHD or the ADD kids, then you're going to want to ask about that and ask the teachers to say, you know, what do you think of attention? Do you have to redirect her? Does she seem off task every time you check in on her? Because those are the types of things that are important there. And then adults, you know, there can definitely be adults who are diagnosed with ADHD. A lot of us, when we were younger, that wasn't even really a diagnosis that existed. And so some adults, after their kids get started on medications, or they start looking into it for their kids, they say, I think I have this. And, you know, a lot of ADHD symptoms do run in families, and there's a genetic predisposition to it. And so, and for the adults, there are other very similar checklists where you would fill one out, someone that works with you or knows you well would fill one out about you, and then that would be, you know, how you would diagnose it as an adult. Yep?
So for diagnosis, should you really do all 4 of those checklists?
No, it's just one. Those are all examples of the different ones. Yeah. You know, the other thing is that there are strict criteria. For example, you're supposed to have 6 in the area of hyperactivity and impulsivity, or 6 in the area of inattention. And, you know, the way I practice as a developmental pediatrician, if there's 5 in each area, does that mean they're not impaired? You know, so those checklists are the absolute criteria of what's supposed to be there, but it doesn't mean that, you know, they might not have attentional problems causing them impairments if they only have 5.
Yeah,
so
I think some of the checklists, they were like only 15 items or something,
yeah.
And it just was silly. It's like, how can you make a diagnosis off that?
Yeah. It seems very silly sometimes, and parents are like, well, I went to the doctor, they gave me some checklists, I filled out 15 questions, and then they wrote me a prescription. And in reality, and in typical kids, that's kind of how it's done. And it feels scary, and as a developmental pediatrician who has a much broader understanding of psychological difficulties that can contribute to attention problems, I'm not sure that's the best approach, but But that is how pediatricians are trained to do it. And so it's not, poor practice to do it that way. It's not as deep as I would like to see everybody doing ADHD evaluations, because there's a lot of other things that can look like ADHD. But that's kind of how it's done. And so, if you're not comfortable with that, and I don't want any of you to be really comfortable with that, because, the complexities of the X and Y variations are much more.
Yeah, we followed up with a psychologist,
Yeah.
and he actually said no.
Yeah. So you want to follow up with the psychologist or someone else who can do more testing and have it, have a better understanding of what's causing the problem.
So I think with the KS kids too, though, if the school is saying they're inattentive before you do anything else, you want to request an OT evaluation.
Yeah.
And make sure that it's not a sensory issue.
Yeah. I think you want to request all the evaluations. You want to request the learning, you want to request the OT, you want to request the speech. Because you need to know everything. You want to kind of look at the emotional factors as well with the anxiety symptoms. So these are the other things to consider. The learning disability and reading disability that we know in the variations, the anxiety that can sometimes really impact you at school. Some kids, some of the girls who have a lot of social anxiety, they'll be kind of inattentive and distracted because they're worried about this, or they're worried about what's coming up next, or, so-and-so is talking and that person makes them nervous. They're not going to do as well, and they're going to look inattentive. And so if you help them with that anxiety, it might not be a primary attention problem. Sensory reactivity or sensory integration disorder, seizures and other medical problems like sleep disorders, and then intellectual disability and mental retardation. If kids aren't understanding something going on in class, if things are going over their head, then you really want to make sure, are you just calling them inattentive, or do they really understand what's happening? I sit in some lectures sometimes, and I look like I have ADHD for all the world, which I probably do have a little bit of, but I just don't understand what's going on, and I'm bored. And I'm not going to, I try and pay attention, and then I'm fiddling and drawing something over here, and, and so, and that's going to happen the same in the kids, and it happens to all of us. So, those are important. In the intellectual disability, in all the talks you guys have been to, this is rare to actually fall in this range in the trisomy conditions. However, it's still there in a small percentage of the population. And so, knowing about the learning problems and where they are from a cognitive perspective is important. We talked about this in ADHD by a professional who understands ADHD, and then it's helpful if they're also willing to learn about the X and Y variations. What you guys will find in your communities is that there probably are ADHD experts. Every city has those, or usually there are some, but they don't always understand the X and Y variations. So, at least if they're willing to understand it, if they're hearing you when you're talking about it and saying, well, what about this other factor, and they're willing to read or learn or something else, then that's good. If they kind of ignore it over and over and over and just kind of follow their path for standard ADHD, then you want to, think about whether or not that's the right professional who's not hearing the other pieces of it. So ADHD in the brain, we know there's a lot of research on ADHD and a lot of places in where we have some information about which parts of the brain are involved, and these are just a few. There's actually a few more that actually are involved. But the frontal lobe is the most important one, and we know that these are actually smaller in the X and Y variations. And the frontal lobe is involved in executive function, which is planning and organizing, attention span, inhibiting impulses, being able to inhibit all those extraneous thoughts and actions, working memory, keeping things in your mind and and remembering them in your mind over and over for a short-term time. And so, and we know these are smaller in the X and Y variations, and we really think that a lot of executive function impairment is what's impacting a lot of the kids with the X and Y variations and also contributing to their ADHD symptoms. Limbic system is involved, and that's kind of emotion and self-regulation, so again, some of the impulsivity. And then the reticular activating system is overall arousal and attention level. So all of these are impacted in the brain in kids with ADHD. And we know the frontal lobe is involved in the X and Y variations. We don't know that much about these two areas in X and Y variations. Okay, so Natalie's going to present our research that we've done on the different variations.
All right, so for our study, we recruited patients from the UC Davis Mind Institute here in California and then the Children's Hospital in Denver, Colorado from 2004 until 2009. And we also recruited kids from KS&A, from Access, from the XXYY Project website postings, endocrinology and genetics clinics, and the Extraordinary Kids Clinic in Denver. So we included kids from 6 to 25 years old from these 4 different variations, XXY, XYY, XXX, and XXYY. We excluded kids under the age of 6 because while they might exhibit some ADHD symptoms, it's a lot harder to say for sure that they have actual ADHD at that age. We also excluded kids that had an X and Y variation but also had another genetic disorder on top of that. For our study, we used the Connors and the SNAP-4 ADHD rating scales that she was talking about earlier. So we had a parent fill out those, and then, if possible, we had a teacher fill it out as well. We performed a cognitive assessment, or either at our clinic, or we accepted one that was performed by someone, another licensed professional, within a year of that assessment. We obtained a history through an interview with the family, looking for other developmental, behavioral, and emotional diagnoses, other medical problems, medications. We performed, finally, an adaptive functioning assessment, which is basically life skills and self-care, general functioning, and day-to-day life. And those tests are either the Vineland, ABAS, or CIBAR all test that. And then this gives a standard score compared to what's expected to other kids around the same age, and it's distributed kind of in a bell curve, like an IQ score of 100. 100 is like the average score in the general population. So these are our kids that we got for this study. We had 21 XXX girls, 39 XXY boys, 26 XYY boys, and 52 boys with XXYY. The ages range from 6 to 21. And the average age was really nice. It was about 11 or 12 for each of the different groups. So bear with me as I go through the next few slides. They're all full of data like this. So we're going to just do one group at a time. So up in the corner of each of the slides, you're going to see a pie chart like this. And it says in white right here, you can see the kids. That's the percentage of kids that were not diagnosed with ADHD, so they had no ADHD. The light blue is that inattentive subtype of ADHD mentioned earlier, and then the dark blue is going to be the percentage of kids with the combined ADHD type. So overall, we had 38% of the XXX girls who got a diagnosis of ADHD, of the 21 girls, and it was about 50-50% kids that were diagnosed prenatally and postnatally. So down here, you're going to see on each of the slides, like for here, it's 27% of the prenatal group was diagnosed with ADHD, 50% of the postnatal group. That seems like a difference right there, but as you can see, it's only a difference of 2 kids, so it's not a statistically significant difference. We wanted to see if there was a difference between the 2 groups of the kids that had ADHD and the kids that did not. So we wanted to see if there's a difference in things like IQ, adaptive functioning, like life skills, or the rate that either one group or the other is diagnosed with other things like anxiety, depression, autism, that sort of thing. So for the XXX girls, these are the average scores of all the girls who did not have ADHD, their average verbal IQ score, their average performance IQ score. And you can see it's a little bit higher for the kids that did not have ADHD, but when we did a statistical analysis, it showed that it's not a significant difference. But however, when we did the adaptive functioning, so that, remember, that's the life skills, the self-care, it was significantly a higher score for the kids that did not have ADHD. But then when we went back to look at other diagnoses like anxiety, depression, to see if there was more in one group than the other, there wasn't a significant difference, even though it's a little bit higher in this group right here. So for the XYY boys, again, you see the pie chart. So there's 23%, that white part of the kids that did not get diagnosed with ADHD. The light blue is the 35% that were diagnosed with the inattentive subtype, and then the dark blue is going to be the combined subtype for the XYY boys. Overall, in this group, there's 77% of the 26 boys were diagnosed with ADHD. So here, it's a slightly higher in the group of boys that were diagnosed postnatally, but let's see, and before, remember, it was a 50% difference between the postnatal and the prenatal group. So here we had slightly higher percentage of kids that were in the postnatal group. When we went to see the differences between the two groups of kids that did and did not have ADHD, again, the verbal and performance IQ differences were not statistically significant as we were going through. It was slightly higher again here, but not significant. But again, like the XXX girls, the adaptive functioning score was significantly higher for the group that did not have ADHD. But then going back down, you can see it's slightly higher down here too, which ended up being a significant difference for the amount of kids that had other diagnoses. So anxiety, depression, autism, and that would be in the group that had ADHD. So for our XXYY boys, we had only one that was prenatally diagnosed and the rest were postnatally diagnosed, so that's why this 100% is right here. That one boy was diagnosed with ADHD, and then we still have the pie graph going on over there. If you want to see how many kids were not diagnosed, it was 31%, and then the light blue is the inattentive, the dark blue is the combined. And when we went to see the differences in the XXYY boys, again, the IQ was not significantly different in either of the two groups. The adaptive functioning score was, again, significantly higher in the group that did not have ADHD. And the rate of diagnoses for the group that did have ADHD was significantly higher for anxiety and depression and autism and things like that. And finally, we have the XXY boys, where, so the white, again, is the percentage that did not have a diagnosis of ADHD. We had overall 36% of the 39 boys were diagnosed with ADHD. When we went to look at the differences right here, you can see that it's exactly the same for the performance IQ, and basically the same, not statistically different for the verbal IQ as well. Again, the adaptive functioning was significantly higher, just like the other three groups, for the group that did not have ADHD. And down here, there was no difference in number of diagnoses of other things.
Quick question about that.
Yeah.
I mean, do you think that just based on with the ones that have the other diagnoses based on the ADHD versus the no ADHD, do you think that's because a lot of times parents that have kids that have ADHD go after those diagnoses to, you know, like in more than the parents that don't have kids with ADHD?
I think sometimes. You know, I think ADHD is one of those diagnoses that is probably the quickest that people are able to apply, and, you know, they will diagnose with most easily. And so the first thing that they go to is, okay, and it's probably the first one. So the kids are having problems. Oh, well, let's diagnose them with ADHD and start with this. And then they go on to say, well, is it also, you know, an autism spectrum? Is it also anxiety and other things? The reason we included that was because we really want to try and understand, okay, so we have these kids who have a diagnosis. What are the factors that impact them? Are they having other medical problems? Are they having other psychological problems? And in general, you know, the cognitive scores weren't different. So I hypothesized that the kids who had the ADHD were going to have lower cognitive scores and that their IQ scores were going to be lower. You know, we always know some that are doing really well and have high IQ scores and still have attentional difficulties. But I thought as a group it was going to be lower, but they weren't actually. And so, you know, but I do think those kids are still the ones who are probably, even though their cognitive scores might not be lower, they're having just kind of more emotional difficulties, and those parents are seeking help and probably receiving a lot of other labels. Yeah. And so this is, you know, the summary of those four charts, and I think what was most striking to me is how similar they are when you look at the pie charts going across each way. That the XXY and XXX girls are very similar in that they have kind of less of the kids are having difficulties with attentional problems, and when they do have difficulties, it's more likely to be that inattentive subtype. Compared to the XXYY and the XYY, where they are much more likely to have those hyperactive impulsive symptoms as well, and we're seeing problems in a larger percentage of the population. And, you know, we do see more kind of externalizing problems, a little bit more hyperactivity and impulsivity in the guys who have the extra Y. And so I think it's kind of interesting to see, you know, the two X's and the two Y's and how they're similar. So the conclusions that we drew from the research are that, you know, in all groups, there's a percentage of the children who meet criteria for ADHD that's higher than in the general population. The XXY and XXX are more likely to show inattentive symptoms, while the XXYY and XYY are more likely to have hyperactivity and impulsivity. ADHD was present in both prenatal and postnatal groups, so, you know, and it wasn't significantly different between most of the subgroups in terms of a prenatal diagnosis kind of, while we think there are, you know, sometimes better outcomes, it doesn't protect you against any diagnoses like ADHD. The IQ wasn't significantly different between those who did and didn't have ADHD, and even those with higher IQs and very high IQs can show symptoms of ADHD as well. Adaptive functioning was lower in all the groups with ADHD, so adaptive functioning, that life skills, how they're actually applying their cognitive abilities to, you know, be functioning in day-to-day life. And those were lower. ADHD was impacting their adaptive functioning. And that actually has been, you know, some of the group from the Netherlands has looked at this as well, in that, you know, adaptive functioning is very dependent on executive function in that frontal lobe, how you are using, you know, all your skills to be able to organize, plan your life, and execute your life. And so I think this is showing that ADHD is impacting that adaptive functioning. And, you know, the next steps are really better understanding that executive functioning and frontal lobes to see, you know, how they impact ADHD and other things. So for the treatments for the ADHD's problems is that there's two main types of interventions. There's behavioral interventions and there's medications. And these, you know, really need to work together. The strategies for behavioral interventions are strategies to support ADHD symptoms. So strategies to improve that executive function, school accommodations to help with the attentional difficulties in organization and planning, and then medications as well. And we'll talk more about those. So, you know, this is really the ideal model of how it should all work, is really a lot of collaboration between the student, the parents, and the school, and everyone working together to come up with a plan of how you're going to address the difficulties in all the settings so that it's consistent and so that everyone's on the same page. And so, you know, the answer is not, oh, he has ADHD, let's start a medication. That's not the whole answer. It's part of the pie, but it's not the whole answer. And so, you know, there have to be plans and strategies that are implemented between the parents, the student, and the teacher. There's a million different accommodations and strategies that you can use to help with ADHD symptoms. These are a lot of the accommodations that we see for kids in general, and there's, like I said, many, many others. But things like sitting in the front of the classroom, you know, we're having the teacher actively work to decrease distractions for the child, communication notebooks or emails between the parent and the teacher about what kind of homework is expected, having, you know, teachers check in and make sure the child's bringing home all the homework and all the materials that they need, you know, having the teacher ask for the homework because the kid forgets to turn it in and then they don't get graded on it. Breaking it down into steps, you know, having timers to help kids stay on task, giving them breaks for movement and wiggles as they need them, having, you know, picture schedules so that the kids can visually see what's coming next and kind of help them stay organized and stay on task, using checklists so that the kids, you know, also stay organized and kind of stay on task, and then having extra time on tests, taking tests in a quiet room, you know, many, many others that need to be developed according to each individual child and where they are in terms of what their needs are in education. The diagnosis of ADHD in general helps you qualify for a 504 plan in school, which is a plan that includes those types of accommodations. The next step after a 504 plan is the IEP, or the individual education plan, which some of, you know, the kids already have. You know, if they have other needs besides just ADHD accommodations, then they do the IEP. I think, you know, not for everybody, but a lot of kids with the X and Y variations need IEPs because they also need speech and language supports or OT supports or, you know, other learning help. But the school psychologist, the special ed team, and the parents and the child, you know, especially the older they get, should determine what each child needs for their accommodations. And then after it's been started, the next important thing is that this should be an ongoing process. It shouldn't just be, okay, we're going to do this at the beginning of the year and then revisit it next year. I mean, if things aren't working, if things aren't progressing, you need to revisit after a couple months and say, well, what else can we do? Or, you know, what's working, what don't we need to do? Those types of things. So for medications for ADHD treatment, which is the other piece, the medication treatments, again, should always accompany the behavioral therapies. My criteria for when to start medications are here, and some of you may have heard this morning at the medication lecture, but if you weren't here, I'm just going to review them quickly. I think that if a child expresses distress about their attentional symptoms, I don't know why they keep going firecrackers in my head. I try to pay attention, but then I think about the trees, and then I think about the princesses in the trees, and then I think about this. You know, they're expressing distress about why they can't stay on task, and that it's bothering them. If it's interfering with learning and academic progress, if they're not turning in their assignments, even though you know they can do them, and then their grades are going down, and that's because they're forgetting and it's inattention and, you know, they're just not organized to do it, or they're capable of doing it if they would remember to bring their book home, but they never remember, well, then their grades are going down because of their ADHD symptoms, and that's a time to think about whether or not they need help with that. You know, if it's interfering with their social development. If they're so impulsive that they're butting into conversations and kids aren't liking them, or, you know, they're hitting or doing other things, then that's another thing that, you know, they're not going to be developing socially, and those friendships and self-esteem are so important for their development. Interfering with just home life and kind of general functioning in day-to-day life. They can't get it together. You know, it takes you 3 hours to get out of the house in the morning because they're distracted doing this, distracted doing that, they're late for school. It's causing problems at home because it's taking you 7 hours to do homework, you know, those types of things, then it's another time. And then, you know, the other thing, I get a lot of concerns, well, I don't want to drug my child. Well, if your child ever seems drugged, then the medication is not right. The medications don't work in the way that you drug them to calm them down. And so, you know, that's the wrong medication, that's the wrong dose. Your child should not seem zoned out, should not seem drugged in any way. So what we know about ADHD medications, we have research studies in terms of ADHD medications in the general population. And I think this is important to talk about, even though it wasn't specific on the X and Y variations, because these studies, called the MTA studies, really kind of shape how ADHD treatment is done today. And what they did in these studies is they had thousands of kids in different groups all around the country, and they divided them into whether they were going to receive just the behavioral treatments, just the medication treatments, or a combination of the medication and behavioral treatment alone, or a placebo. They weren't going to receive anything. And these are the results, and they might be kind of hard to see here, but basically, these were the scores at the beginning, and the higher the scores, the worse off they are. And so these two groups up here were the placebo group and the behavioral intervention group. And what you saw was that the scores came down if they had just a placebo or if they had a behavioral intervention only, and they came down to there. However, these two groups were the medication alone and the medication plus behavioral interventions. And those groups came down significantly more. And so what the results of the study showed us was really that medications alone were better than behavioral treatments alone. Medications and behavioral treatments together weren't really even that much different. So, however, so it told us medications are a really important part of the treatment in ADHD symptoms. Even though there weren't significant differences here, I still don't think it's right to let's just start medication without helping the kid come up with some strategies and ways that they can learn some of those skills that they're going to need for life. So the medications that we use for ADHD, the classic and first line recommendation are the stimulants. There's two different types of stimulants. The first one is called methylphenidate, and these we commonly know as Ritalin, Concerta, Metadate, Focalin. These are the brand names, and these are, and there's lots of other ones as well. But these are the methylphenidate products, and basically they all have just different formulations of methylphenidate in them. There's short-acting ones that work, just for 3 or 4 hours, and you have to give them multiple times per day. There's long-acting ones that last anywhere from 8 hours to 12 hours. And then there's the amphetamine salts, which are Dexedrine and Adderall. People typically use Adderall most of the time now. And then there's non-stimulant medications that include Strattera, and then there's other ones as well that we use as kind of second-line agents that are 10X and clonidine, and then also sometimes the SSRI medications, the anti-anxiety medications, well, Butrin and Zoloft, and those are also used for attention problems. This is a list of all the different ones, so there's, like I was saying, short-acting, intermediate-acting, long-acting, of all the different kinds. You take them either once or twice a day. They last for different amounts of time. This is the breakfast cereal. It's a joke. We don't really want to give them to everybody. Sometimes I think some teachers might want to feed this to their kids, though. This is the chemical structures. I put all these in there, I told the other group, just so I look really smart, like it matters to me. But you know, these are the different chemical structures of the different medications. You know, but basically, the reason I'm showing it is because they're kind of look-alike molecules for dopamine and norepinephrine, which are important in the brain. Because what they do is, you know, people ask me, well, how does a stimulant, you know, actually calm kids down? Or how are you giving them something that's like an amphetamine product to calm them down? And the way it works is your frontal lobe is in charge of inhibiting impulses and kind of organizing your life. So you're stimulating your frontal lobe to be able to inhibit and organize and plan and pay attention. Does that make sense? So, you know, you're actually stimulating something to be able to inhibit.
I have a question. My son's on Concerta and clonidine. So
Okay.
what's the reasoning for the doctor putting him on a stimulant and a non-stimulant?
Right.
I mean, he takes Concerta in the morning.
Yeah.
Clonidine at night.
Yeah.
So does that really...
There's a couple, so sometimes if you don't, okay, so there's a couple different reasons, and I don't know why. Well, there's a couple reasons. So first of all, the Concerta, which would be the daytime stimulant medication, helps you during the day. Sometimes one of the side effects of that is having problems sleeping at night. And then it will start clonidine for that. I don't like that because to me that's treating a side effect with the medication. Now, sometimes kids on Concerta, they're still not quite right. And they still have some of that hyperarousal. I don't know if you guys were at the morning lecture, but we talked about hyperarousal and being those kids who are kind of really sensitive to sensory stimuli. And the Concerta doesn't always help that 100%. And so sometimes they also have an extra component of hyperarousal. And then if the Concerta is helping a little, but they still seem like, you know, and you don't want to keep pushing that Concerta dose up, or you can't get it any higher without causing other side effects, you might add another medication like clonidine to help with that hyperarousal, which can then help more. Clonidine is typically given at night because it can be sedating, and so you want the sedation, you know, and you may or may not be using it for sedation at night, but then the effects last during the day as well. Sometimes in some kids you see daytime effects even though you give it at night.
She wasn't having trouble sleeping.
Yeah.
He said they were doing it because he was still being the impulsive.
Yeah.
So
Did it help? Sometimes some kids need clonidine like 2 or 3 times a day. You know, sometimes it only lasts for a short time at night, and then, you know, so they're getting the effect overnight, and then in the morning it's already gone. So, yeah.
I was just going to comment on that because my son takes clonidine too. He takes Ritalin during the day and clonidine during the day and at night. But the reason he takes it is because if I think he's on so many different things it's hard for me to it's like his cocktail.
Yeah.
But he is on the clonidine, I believe it's for OCDs. Is that possible? I know he's on fluoxetine for something.
That's for OCD.
Okay, but then he's on the clonidine because he has some tic disorders.
Yep, clonidine can help with
Yeah,
tics.
and that's why, and he has the brow picking,
Yeah.
whatever,
Yeah.
and that kind of stuff. So he did it for tic disorders, and that's why he continues it. So when we run out of it, he starts back.
You can see him
Yeah.
start again. Yeah. Clonidine, you know, those hyperarousal medications can help a little bit with that hyperactivity, and it helps a little bit with that anxiety, and, you know, so some of those things. And it definitely can help with tics. It works on that dopamine system, too, and help with tics. So
How come you didn't ask Vyvanase or Vyvanase or whatever?
Vyvanse is a new one, and it's in the Adderall category down here. And I don't use it much because it's new, and I kind of like the old standbys until we know. You know, if I've tried other things or if parents want to try it, I'll try it. Focalin's fairly new, but it's not as new as Vyvanse. Yeah. I don't use Focalin much either. I mean, my favorites, although I'm not endorsing anything. I'm not going to say that. I don't think I'm supposed to. I use a lot of Concerta. And I use a lot of still. People think I'm old-fashioned, but the short-acting medications that you have to use a couple times per day, when I'm starting kids, I'll often start them on that, especially if they're younger, because, you know, you can get a better sense. You can do it a little more quickly on how you can up the dosage. It comes in dosages that you can change, and then you can figure out what exactly they need. So that was the old-fashioned way. You don't have to do it that way anymore. So most people will just start with the long-acting one. But, you know, I still use a lot of those kind of older ones because they're a little simpler sometimes. And they're not expensive, you know. A lot of them, they just come up with new ones because they can have a brand name that they can then sell and market. But they all are the same medication in the end. Now, some kids do respond better to one than the other. And they're released at, you know, the other way you decide is, can they swallow a pill? Because some of them are capsules you can open. Some of them come in liquid. And then, you know, and some of them are designed to release at different times. Some kids need more control in the afternoon, or they have a lot of afternoon irritability with Concerta or some of the other ones. And Metadate is, you know, released more in the afternoon, and so it actually helps with that. And so there's a lot of, you know, there's different reasons why, depending on how kids are reacting, you might change medications based on how the medication is released. So what should improve with the stimulants? Well, basically, the ADHD symptoms that you're seeing should improve. Less overactivity, better attention span, less impulsivity, more self-control, more compliance, you know, less physical and verbal aggression if that's coming from ADHD symptoms, better social interactions if those, you know, ADHD symptoms are impacting them, improved academic work productivity and accuracy. What doesn't improve is language disorders, you know. Reading skills, social skills don't necessarily improve. The core problems with those won't improve. If their ADHD symptoms are impacting that, it will improve those pieces. But it doesn't improve cognitive abilities. It doesn't improve IQ to start ADHD medication. You might get better results on an IQ test because the kids are able to attend and focus. But, you know, there's still, if someone's IQ, optimum IQ is here, the ADHD medication isn't going to help. If their optimum IQ is here and they're performing here because of attention and distractibility, then, you know, you'll see them come up there. And so, but it doesn't, you know, actually improve IQ. It can help academic achievement in terms of helping with grades and things. So it can improve that, but it doesn't necessarily, you know, again, improve your overall cognitive level. So the nice things about ADHD medications, at least the stimulants, are that they work the day you give them. If you miss a dose, there aren't problems with it. You know, you just miss the effects that day. It's not like they have withdrawals or there's any problems with missing it. Some people use the medications just on weekdays for school. Other people use it every day, and it's okay to do that. You know, usually in a 1 or 2 week trial, you can really see if it's going to make a difference. Sometimes people see immediately, you know, in the first couple days. So, so you can tell if it's going to be effective fairly quickly. Those are the stimulants. The non-stimulant medications, Strattera, the SSRIs, those ones take a few weeks, and you have to actually work up using the dosages. I mean, Strattera takes 6 to 8 weeks to get up there. Yeah, Michael?
I just want to say, don't start your kid off super high of a dose, because I was on 20 milligrams non-extended-release Adderall, and the first day I had suicidal thoughts. So.
Yeah. So we worry about, I always start low and go slow and make sure you're starting on conservative doses. The side effects can be decreased appetite, sleep disturbance, headache, exacerbation of any tics that are there, agitation. People talk about growth problems being a concern. It doesn't stunt their growth. And what we know now is that it decreases their appetite. And so, you know, kids who are tend to be very overweight also tend to grow and be very big. And so what it does is it restricts appetite. It might not actually be that much. You know, sometimes it's this nice side effect that it decreases appetite for some of the kids that we know are, you know, eating a lot and overweight as it is. We never use it for that by itself, but, you know, sometimes it's a beneficial side effect to have. And the other things that we sometimes see, you know, behavioral agitation. You know, if the doses are too high, you can see them get a little bit irritable and sometimes have, you know, just more agitation. In extreme cases, sometimes some people will just have a really strong reaction and they will, you know, be really affected by it. Most of the time that doesn't happen, but it's something, you know, we warn you about before you start in case, you know, you start on the weekend in case there's going to be problems in terms of medications and behavior and responses. And then there's one other thing I wanted to say. Oh, you know, if there's any underlying history of any heart disease, we also think it's important to get an EKG or to just get clearance by the cardiologist because it can have an effect on the heart. Some kids will say, my heart is pumping fast, and they can feel it. That usually goes away after a couple days. Like, they kind of get used to that feeling. Is it what? No, it's not fibrillation. It's just that it's a stimulant, so it actually increases your kind of your heart rate a little bit. It can increase, but it doesn't actually cause an arrhythmia. Yeah.
Also, can there be a tendency towards depression, or is that mostly because the Adderall sounds a little bit like what we have with an antidepressant?
Not typically. You know, that's not. There's not a warning on the ADHD medications for suicidal thoughts.
Let's say with the Adderall, I think it was when you came off the Adderall, the end of the day, it would have a drop.
Yeah. So that's really important, actually. Yeah. So one of the things you can see, and you know, if they are having irritability, is paying attention to when it is. There is something called rebound irritability, and it's that time when the medication is wearing off. And for some kids, they can tolerate different response drop rates differently. So if they are getting more irritable just at that time in the afternoon, you actually do a formulation where that drop would be slower. So.
Meaning that it would be a different drug that would be introduced in the afternoon. Is that what you're saying?
No, but like one of the formulations you can take, like Metadate CD, you take it in the morning, and it's just the way that the little, you know, pills are inside the capsule. There's some that are released in the morning and some that are released later in the afternoon. And so within that one capsule, that tends to be, you know, released more in the afternoon and then slower. You still have effects in the morning, but the way that the time release of the medications are different. Now, sometimes you add it in the, you know, you have, like, we love how Concerta works, he just gets irritable. And so you can sometimes add a little extra dose of those short-acting ones in the afternoon, and then that helps them kind of just come down a little bit more slowly. So there are things you do where sometimes you do add afternoon doses, but other times you can just switch it to a Metadate or a different formulation that has that, you know, afternoon difference release. Yeah?
Is there one that helps with the weight issue better than the other, like Kyle's gain weight? He's
Yeah.
so skinny, and we tried so many different things, and he just has no appetite.
Yeah.
And they're already kind of tall and thin to begin with.
So is there
Some of them.
Is there anything you would recommend with that?
Yeah, so, right, basically the lowest the dose you can tolerate. The other thing is sometimes that's where the old-fashioned medications come in, where, you know, it's really convenient to give it just once a day, but being able to use the other medications where you give it in the morning, it kind of comes down, you give it again at lunch, and it comes down, and so they actually are hungrier in that lunch period when it wears off. With those, you know, when we have kids who are having a hard time gaining weight, you know, you give it to them with a big, huge breakfast. You feed them snacks they don't even think are really snacks throughout the day that are really high calorie. Here, have a milkshake, you know, have some peanut butter, have some ice cream. You know, you do what you can to give them high calorie snacks that they're going to eat. You send them to school with lunch that's going to be, you know, their Ensure bottle or, you know, whatever things are, you know, they're not going to eat the gross tuna sandwich, but, you know, you give them stuff that they're going to like. And then, you know, you just work on dinner. And then sometimes, if that's still not enough, you do another meal before they go to bed. And so you do a whole other meal, you know, before bed.
We have a problem just like with wanting food. I mean, he just doesn't really want food.
Yeah.
Whether he's on the medicine or not on the medicine, food just isn't that interesting.
Right, right. So then you got to, so you got to be really careful with these. Strawberry quick even? No. Chocolate milk? Gosh. So, and then these are kind of the other ones. So these are the non-stimulant medications. I don't use atomoxetine or Strattera that much, mostly because the stimulants really work. However, you know, in some people I've heard in other conferences, oh, you know, Strattera isn't good for XXY. Well, I haven't had any bad. I've had kids that don't respond to Strattera. I haven't had any horrible reactions to Strattera, but I've had kids without XXY not respond to Strattera too. So I don't think it's XXY or, you know, the X and Y variations don't respond. I just don't know. I have had some kids do well on it because Strattera also can impact anxiety and help with anxiety symptoms. So some of those kids who get kind of more irritable or agitated on the stimulants and they have some anxiety, it's actually, you know, those are the types of kids it seems to work better on. Mm-hmm.
That's the one thing that I would warn about Strattera though is something that happened to us, and that is when we came off of Strattera, Will became manic depressive. I mean, you can't just come off of it really fast. You have to slowly come off of it because he's basically, you know, he's a pretty nice kid, and he threatened to kill his teacher.
Yeah.
And that's not how it usually is, and that's not to say for anybody who's newly diagnosed or anything that you're good, but that's just coming off of medication.
Yeah. Strattera is one that you have to go up on really slowly, which is why it's kind of a pain in the butt to use, and then you have to come down off really slowly. And so, you know, it shouldn't be stopped abruptly because the chemicals then don't know what to do. You know, your receptors and other things need time to adjust.
But you can switch to another something.
You can switch
while
to...
you're, and
yeah.
when you go off of Strattera, have something in place of it. Like we went straight from Strattera to Ritalin.
Mm-hmm.
We didn't back, I don't think we backed down slowly, or did we? Do you remember, Jim? Did we go slowly, or did we just, I think the doctor told us we could just go straight on into it.
You should always wean off of Strattera the same way you go on it. And Ritalin you can start and stop. I mean, you know, that one doesn't matter.
I know what he did. He started us on a little bit of Prozac while he was weaning off of Strattera.
Yeah.
So that they wouldn't be the same, and you know, overdose, whatever.
Yeah. So,
I mean, not Prozac. What's the other? Ritalin. What did I say? Ritalin? I don't know. But anyway.
Okay. So the adrenergic medications are the ones that we were talking about for hyperarousal, which are clonidine and 10X or Catapres, or clonidine and guanfacine are the generic names. These can also help with hyperarousal, hyperactivity, sleep, and aggression. They can be used in younger children. A lot of times, you know, 3, 4, 5-year-olds who are having a lot of difficulties, you know, I wouldn't start them on a stimulant. That's pretty young. And so, but these can help in some of those areas, just kind of calm things down a little. The side effects aren't there. They're not, you know, a lot of side effects. If anything, they can be sedating, and that's why sometimes they're used for sleep. And so this, and sometimes, like we were saying, these are actually added to the other ones. And so they don't, like a 12-year-old, yeah, sometimes I'll start them on this to start if I see a lot of hyperarousal symptoms. But usually the older they get, the less effective these are in terms of hyperarousal. Or they help you, but they're in addition to something else. It's rare to just have a kid on this. But I actually do have a couple kids who had horrible reactions to all the other medications and, you know, doing great just on a little bit of 10X, and that's helping him. And so, you know, there are some kids where even when they're older, you know, these are really the right fit for what their brain needs. You know, in the treatments in adults, if people have questions about that, you know, the adult treatments are pretty similar. When we watch how often they need to go on and continue medications in adulthood, about 50% of people who are diagnosed with ADHD in childhood need to continue into adulthood. Or, you know, say they still benefit from medications in adulthood, whether or not they still take them. And others seem to really not need them as much. The natural progression of ADHD as well is that in childhood, there's more of those hyperactivity and impulsivity symptoms, and then as they go through adolescence, those go away, but the inattentive symptoms don't necessarily go away. And so, you know, in my feeling, what we don't know those same time courses in the X and Y variations yet. We don't have a lot of research. But in my working with some young adults, they still tend to need those ADHD medications, and a lot of them say, I really definitely need it to be able to continue. So, so then they're continuing on them.
Do you see an impact of testosterone in their need for now?
No, thank you for asking that. A lot of adults will say, when I need my shot, or when my testosterone is low, I know because I can't pay attention. So we're actually studying that in a research project right now where we're studying attention and other things, cognitive skills, motor skills, before and after starting testosterone. In our pilot data that we have, the ADHD improves, within 6 months even. Even the inattentive piece of it improves 6 months after starting treatment. So what I say to that, but it still isn't the only answer, So what I usually say is, okay, if kids are coming and presenting at 12 or 13 and you're seeing a lot of attention and concentration problems and you know it's time to start on testosterone, we'll start them on the testosterone and then see how they're doing. If it doesn't help with the attention and concentration, don't be surprised. It's not, we know in the X and Y variations, it's not the only reason why they would have problems with inattention. The XYY boys have tons of problems with inattention and they don't have the testosterone piece. So, but if you're going to be starting the testosterone, start the testosterone, and then revisit it, 3, 4, 5 months later, or how are the attention problems going, and then if they need medications for that, then you would do that. Yeah.
You were saying how on the stimulants that you can start testosterone and all that. I've noticed, I take Adderall the same as Stephen does, and if we don't take on the weekend, we're very irritable. Both of us are. So,
yeah. So you continue it on
your
the
body
weekend.
just come accustomed to having that, though.
Yeah.
Since you're taking it all week and then you stop it.
Right.
It's like, oh, wait a minute.
Some people do and some people don't. So, some kids, you see them, wow, their whole behavioral regulation is better on it. So then, is it fair to take them off and then start them again? Like, they actually do better with it and they feel better and they're, calmer and it's easier for them. And so, then, I'm not sure you want to stop it on the weekend. Some parents, especially with the appetite and other things, some parents really need to stop it on the weekend if it's impacting growth and things. Well, then you better keep taking it. So, our responses to medications in these 3 different groups is really, in the first line, starting the first medication and doing it for 3 months, 68%, 72%, 65%. This is a little lower than if you do standard ADHD literature. Response to first-line stimulant medication is usually about 80%. And so the reason it's lower is because these kids are more complex. There's more stuff going on, and it's not just simple ADHD when it is there. And so I'm happy to take any other questions.
What was the percentage in XXYY?
It's about the same, 68%, 70%. Yes.
Old-fashioned question. I still have parents that will give their child coffee in the morning or whatever you call them, Is there any validity to that?
It's kind of an old... the woman who trained me, who didn't train in kind of new current ADHD treatments, used to use that as her diagnostic strategy. We'll give them some coffee and see if it helps him. And if it helps him, we'll start him on meds. That's not what we do anymore. But there are some kids who it's a stimulant. And so coffee is a stimulant and it can help. And so, yeah, I don't know that it's any worse for you than a medication, right? I mean, but so I don't think it's bad to do that. I just don't, it's definitely, if kids don't respond to coffee, like if you give them coffee and they don't do any better, it doesn't mean they're not going to respond to a stimulant, though. So, but I mean, a little coffee is not, not that much different. Yeah?
What did you say was the percentage that continue on the medications in the adulthood?
We don't know in the X and Y populations. In adults, in teenagers now who are diagnosed, they say 50% at least say they need or would continue to benefit from ADHD medications as adults. Some choose to take them, some choose not to. I would say in the X and Y population, it's higher than that.
That was the inattentive category, or okay,
Yeah.
the other?
The hyperactivity and impulsivity usually decreases. You know, the hyperactivity usually decreases. The impulsivity and like lack of inhibition does not always go away. So you can see those people who are still, you know, a little disinhibited, even though they might not be bouncing off the walls. Yes?
Is it possible for the body to adapt to the medication and need a higher dosage later on down the road? I've heard rumors about that.
Well, you know, as the kids grow, their bodies usually need more because the doses change as they get bigger. So that definitely is true. There are some, you know, people, adults who are kind of pretty stable on a dose because their weight is pretty stable, and then, you know, they say it doesn't seem to be helping quite as much. So you go up, if you're going up and going up and going up, then, you know, I would be interested or concerned about knowing what else is going on. Is there something else going on in the brain that's causing them to have more and more attention problems? Yeah?
This doesn't really have to do with, hopefully, the younger kids, but are there the sexual side effects associated with these as there are with antidepressants?
No. Unless you're using Strattera. Strattera has the same black box warning because it acts in a lot of the same way as the antidepressants. It actually was first introduced back in the time for anxiety when Prozac and Zoloft and all of those started coming out. And those got a lot of press. You know, that was the thing to be on. And so they kind of put it on the shelf for a while, and then they reinvented it as the ADHD medication. And so, so those types of warnings about sexual side effects in adults in Strattera are also true. And then also, you know, they may exacerbate depression or suicidal thoughts and other things. So they're important to watch for.
Just, you didn't mention, but our son seems to respond better rather than just kind of stay away from just that. Do you have concerns about Ritalin?
No. You know, Ritalin has a bad name as Ritalin, but Concerta is the same exact thing, and that doesn't have a bad name yet. So Ritalin got a lot of bad press because, you know, I think there was overdiagnosis of ADHD, or, you know, the concern that just a checklist would get you a prescription, you know, those types of things. But I use a lot of Ritalin. Yep. Yeah.
There's some research, I'm not new to that, you know, hopefully we can believe it, but, you know, what are the long-term effects of taking drugs for so many years, starting really young and continuing on to?
Yeah.
So I'm curious to hear about some of that.
Right. So, you know, stimulants are actually, we've been using stimulants for longer in children than we've been using Tylenol. We have a lot more safety data on long-term effects of stimulants than we do in long-term effects of Tylenol and ibuprofen in kids. So stimulants have been used in kids for attentional problems and behavioral difficulties for a very, very long time, starting with the amphetamines and the methylphenidates and those ones, and then kind of carrying on. So as far as we know, the long-term effects that from a medical standpoint that you look for are, you know, people say, well, does it stunt growth? You know, are they shorter? Is it causing problems there? And that's related to the calories, like I said. And if you take big groups who have been on them for a while and not on, you know, and compare groups, you know, the difference is like 2 centimeters, which is half an inch, which I don't really worry about too much in our populations, especially who are all going to be tall. And I think it's maybe that they were just normalizing or decreasing caloric intake, you know, and in our age, normalizing caloric intake a little more. In terms of cognitive effects, we don't have any long-term data that suggests that they're cognitively lower. You know, a lot of data supports that, you know, treating them appropriately for ADHD keeps them, you know, decreases their risk of having problems with drugs and alcohol, other social problems, other things that ADHD behaviors can get you into. Now, this is in the general population and not in kids with X and Y variations. The important things with stimulants in adolescence, and I warn this and tell this to all the parents, is, you know, right now they're a very cool party drug. And so I don't think the adolescents themselves should have access and ability to their own medications because, you know, we have some, you know, selling them, other kids stealing them, other kids, you know, taking them from them at school. And, you know, so you want to just make sure the parents are, you know, have control of that medication and it's not something that the kids, you know, have control of also. So, well, good. It was so good to meet all these new families here.